In this video, we are going to discuss how to differentiate between depressive episode and grief reaction. Grief due to death in the family, and depression could be a part of a bipolar disorder, or it could be part of unipolar disorder. So, uh, what are those parameters which can help us to differentiate between whether we are encountering a depressive patient, or we are having a patient who is reflecting, who is exhibiting grief reaction. So there are few clinical parameters which can help elucidating in these two clinical situations. First of all, in relation to depression, we should be able to evaluate psychomotor retardation, because psychomotor retardation and again marked retardation is typical component of depression. In grief reaction, it is unusual to have psychomotor retardation. First, this is first point. uh, Family will report, patient will report that patient is not moving around, patient is bound to bed, and patient is having decreased sleep, disruptive sleep, patient is having decreased appetite, and these all parameters are included in psychomotor retardation, and biological function become also disrupted in psychomotor retardation. And again, it is typically associated with depressive illness. In grief reaction, it is unusual. Secondly, come feelings of guilt. The patient who are having grief reaction, they could exhibit guilt feelings, but the guilt is limited certain circumstances. Guilt is associated with the lack of care. Patient may say, I think I might have done more to the deceased one. Uh, I should have attended him or her more, uh, and similar feelings. So guilt is linked and associated with typical circumstances, typical individual. On the other hand, in depression, grief is generally overwhelming. When you ask the patient any trivial event in past, patient usually color it with feelings of guilt. There are no event in past life, things in the past committed by the patient which are separate from guilt. So there is global feelings of guilt when you talk with the patient. And thirdly come self-esteem, very important point. In depression, there is global loss of self-esteem. Uh, Whenever you talk with the patient, you talk about his successes, you talk about his individual life, you talk about his family life, you talk about his future prospect. You will see in every aspect there is loss of overwhelming and visible loss of self-esteem. In comparison, when we talk a patient who is having a grief reaction, loss of self-esteem is not that much typical. There could be certain feelings in relation to again guilt, but global loss of self-esteem is atypical in case of depression. And fourthly comes mood reactivity. In depression, usual persistent mood is up, that is low mood. Patient is having a persistently low mood. There is least chance that patient become reactive to positive life event. In comparison, if we talk with patient who is having grief reaction, there is reactivity. Even right now, when you are doing mental state examination, when you are assessing the patient, uh, if there is some positive thing coming out, patient will react positively. So that again points against the depressive illness, and that could be a grief reaction which you are dealing right now. And again, a very important point is suicidal thoughts. In depression, there is hopelessness. When you evaluate suicidal thought, it comes through hopelessness. You will see clearly these suicidal thoughts, suicidal feelings are coming through hopelessness. Patient is seeing as a ray of hope in death, because he or she is overwhelmed by depressing feelings, pessimistic thoughts. And in comparison to depression, when we are talking with a patient who is having grief reaction, uh, such global and overwhelming feelings of pessimism and hopelessness are not there. But patient might say, I think I could have joined my loved one. Such feelings are common, but there is no hopelessness and no such categorized thought and no planning that patient will commit suicide. So we think these are few clinical parameters if we keep in mind when we evaluating depressive patient in comparison to a patient who is having a grief reaction. So these are very helpful. They not only enable us to assess the risk and categorize the risk, but we are also quite capable to delineate and to plan our further treatment in that regard.